Hi, my name is Dr. Leah. I'm an obstetrician gynecologist with the ONG Consulting Group. My topic today is first trimester screening investigations. And it's obviously a huge topic, so I'm going to be mainly focusing on vitamin D and TSH screening, NIPT and genetic carrier screen. So these slides, I've listed the usual investigations that we all know about, so I won't go into them. I will just mention that I think it is worthwhile doing hemoglobin A1C in the first trimester if there's a family history of diabetes or past history of GDM. I I order an additional OGTT at about 16 weeks if there is high risk of GDM. I've got this slide showing the antenatal serologies, which again you all know about, so I'm going to skim over that. If I get a patient who's vegetarian or vegan, then I will certainly check their B12 and folate status. I would aim for ferritin above 50 in the first trimester and over 20 in the second half of the pregnancy. Now the big question is, what do we do about vitamin D screening? So let's look at what the Ranscott guidelines say. Okay, so it says do not screen at all, irrespective of maternal risk factors, and that would be previous levels, skin color, and amount of sun exposure. And instead, everybody, so all pregnant women, should be on 400 international units of vitamin D as part of their multivitamin supplementation. And the reason for that is because the studies have shown that supplementation with vitamin D, or routine supplementation, while it increases the maternal and cord blood levels of vitamin D, it actually does not improve the maternal obstetric outcome, it doesn't improve the infant vitamin D levels, and it does not improve the neonatal measures of bone density. However, I think what the guidelines don't cover is that what about the long-term benefits of adequate vitamin D? And that would be skeletal, meaning bone health, and extraskeletal benefits, including muscle strength, decreased susceptibility to viral irritation, and the anti-inflammatory properties of vitamin D. There has been a recent podcast by Professor Ebling, who is the head of Department of Medicine at Monash, as well as he's an endocrinologist himself, and he talked about all those long-term benefits, and he also concluded that there may be some prophylactic and therapeutic effects of vitamin D on COVID-19, which is obviously quite topical at this point in time. So my approach, which is different to Ranscott guidelines, is that I would screen, and I take this as opportunistic screening. So I would check once and I supplement if it's deficient, and that's probably in addition to the multivitamin. If it's been checked prenatally, then I won't check again. Our next contentious topic is about screening for hypothyroidism and TSH. So again, let's have a look what the Ranscott guidelines say. And it says that we should do, or it recommends overt screening for overt hypothyroid, and not screening for subclinical hypothyroidism or screening for TPO antibodies. What are then the adverse pregnancy outcomes from hypothyroid? And that would be pregnancy loss, preterm birth, preeclampsia, and neurodevelopmental delay in the offspring. Given that they are all quite significant adverse outcomes, and it begs the question of whether we should do universal screening versus targeted screening. This slide explores the arguments for and against universal screening. So for the arguments for would be the overt hypothyroidism may be asymptomatic, and I've certainly had cases where if I did not do universal screening, I wouldn't have picked it up. The incidence of overt hypothyroid is about 0.3 to 0.5%, and that's similar to many other conditions we screen for. So if we're screening for others, then why don't we screen for this one? Especially knowing that thyroid replacement in overt hypothyroid will actually prevent the adverse outcomes. The against argument is that by doing universal screening, we're going to have or pick up all the extra cases of subclinical hypothyroidism, and that lead to extra treatment. And the problem is that there's no clear benefit of treating subclinical hypothyroid in pregnancy. So what would targeted screening look like of TSH or for hypothyroidism? So the ACOG guideline, which stands for American College of ONG in 2015, and the American Thyroid Association in 2017, they both recommend screening for women at high risk of thyroid dysfunction before they become pregnant or in early pregnancy. So therefore, what risk factors do we look for? Now, this is a list of the risk factors as stated in the American Thyroid Association 2017 guidelines, and I draw your attention to risk factor number 4, which says maternal age greater than 30. So I looked into this further, and the stats in Australia is that in 2016, 48% of the women were over 30 years of age when they had their first baby, and that figure is going to be a little bit higher now and again. So by the time we include all the other risk factors, I would say that we'd be screening well over 50% of the pregnant population. And my argument would be, if we're going to be screening over 50%, then we might as well screen everybody. As I said earlier, the increasing doing universal TSH screening is going to pick up more cases of subclinical hypothyroid. And I think that's actually a good thing, especially picking up the subset of women who have subclinical hypothyroidism and TPO antibody positive. And this is because this subset of women have a lifetime risk of developing overt hypothyroid. The problem of subclinical hypothyroidism in pregnancy is that the trials have come up with conflicting results. So there were early trials that did show adverse outcomes, and that led to all of us jumping to do thyroid replacement when the TSH was over 2.5. We've now actually moved away from that, and then there were being later trials which were better designed, so randomized and bigger numbers, that have shown no difference in obstetric and neurodevelopmental outcomes. The problem with those two trials are that the thyroid replacement only started at 13 weeks gestation or 18 weeks gestation, and many would argue that's far too late to see a difference in neurodevelopmental outcome. I see the progression from subclinical hypothyroid who are also TPO antibody positive to overt hypothyroid being a progression of the condition. So if we can clearly document adverse outcomes from the overt hypothyroid, then I think there are also probably adverse outcomes from subclinical hypothyroid. It's just that they are not as clearly demonstrated or easier to, or less easy to show. I will also like to point out that this subset of women are also at risk of developing postpartum thyroiditis. So if we know about it earlier, then we can actually screen for it by having more testing postpartum. I do need to point out that antenatal treatment with thyroxine would not prevent postpartum thyroiditis. So this is a summary of my approach with regards to TSH screening, and this is after consultation with some endocrinologists. So I do universal screening, so obviously this is different to what the RANSCOG guidelines suggest, and I don't repeat it's been checked recently pre-pregnancy. This is a flowchart that I've got looking at how to manage this situation. If the woman is less than 6 weeks pregnant, then I use the non-pregnant TSH reference range. At greater than 6 weeks, then the usual value here we use is about 3.5 to 4, and that is lab or assay specific. If it's greater than 3.5 to 4, then I would order reflex TPO antibody and T4, and obviously I'm more likely to treat if the woman is TPO antibody positive. If the TSH is greater than 10, then we definitely need to treat. This is a flow chart from the American Thyroid Association, printed in their 2017 guidelines. It is actually quite similar to what I've just described, except that they use the cutoff of TSH cutoff of 2.5, and we would mostly use 3.5 to 4 here now. Moving on, I'm going to be talking about aneuploidy screening. I'm going to just skim past the combined first trimester screening because we've done it now for years. With NIPT, we all know it's a 99% pickup rate of trisomy 21. The results are available earlier because it can be done from about 11 weeks, and most companies also offer the extended microdeletion panel at extra cost. This is with the exception of Percept by VCGS. I should point out here that the positive predictive value from the extended panel is actually only at 4%. I get asked a lot as to which NIPT that I would use because there are so many out there. Now, with respect to trisomy 21 screening, I think they're all much the same, so you can use whatever. I do tend to use the Percept one from NIPT, and the main reason for that is because it looks at all 24 chromosomes, which means that apart from the trisomy 13, 18, 21 and the sex chromosome aneuploidies, it will also pick up the rare autosomal aneuploidies, and that has a 65 to 70% clinical utility rate. It will also pick up partial deletions and duplications greater than 7 megabase, and that is essentially the extended panel that other people are talking about. I also have a case at the moment where the maternal malignancy was picked up because of NIPT. So the initial phone call I got from VCGS was that we are seeing a lot of bizarre maternal DNA. We don't know what it means. Let's do a repeat, and the repeat NIPT showed exactly the same result. And then the subsequent phone call was, we think this might be a maternal malignancy that we're dealing with because we've seen this before. So we went hunting for it, and a B-cell lymphoma, and it's actually quite an aggressive form, was diagnosed. This patient is now at about 26 weeks, and she's having chemo and is, doing very well. I'm going to quickly just talk about the first trimester morphology scan. I think that should be recommended for everybody, either as part of the combined first trimester screen, or even if the patient does have NIPT, I think it is still important to do this morphology scan before the formal one at 21 weeks. I would just mention as a one-liner here the option of preeclampsia screen. I'm not going to talk any further because this is actually part of Dr. Natalia Komko's talk. So moving on to our last topic, which is reproductive genetic carrier screen here. So I'll make a plug here for that to be done ideally pre-pregnancy if at all possible. Family history is obviously very, very important for the couple. We should offer, we should do thalassemia carrier screen for all women, and that can just be basic screening with FBE or more specific assays for women from high-risk ethnic population. We should offer the triple panel of cystic fibrosis, Fragile X, and spinal muscular atrophy to all women, or we can also offer the extended panel covering 250 plus genetic conditions. We should remember the Ashkenazi Jewish carrier screen, although that's mostly now done at the school level. The next slide looks at the comparison between the 3-panel carrier screen versus extended panel. So with the 3-panel screen, about 1 in 1,000 couples will have a child with one of the conditions, and this is in contrast to the extended panel. It will pick up about 1 in 700 to 800, so it's a slight increase in pickup rate. And because we're screening for so many conditions, 250 to 300 conditions, 75% of the couples will be a carrier of some sort, and most of them will be non-significant. However, this means that we should really offer, and most companies recommend, the couple testing as opposed to sequential testing, because most couples will end up with sequential testing anyway. I think from a cost-effective point of view, then the 3-panel screening carrier screening will in fact pick up majority of those conditions we screen for. However, if we get a couple who want everything possible done, then by all means offer the extender panel. I'd just like to conclude my talk here with showing a couple of slides, just reminding us how overwhelming that first visit can be for the couple, because we are, they are really suffering from information overload here. There's so much information we've given them, and it's just something that we should bear in mind. So thank you for listening. I hope that it's been useful, and please email us if you have any questions.